In the next minutes, we will talk about the root meniscus tears, the diagnosis, and the appropriate treatment. First of all, we must now know a definition, a clear definition. What is a meniscus tear? Meniscus tear is a radial tear or avulsion of the meniscus, mainly in the posterior horn attachment, but it can happen in the anterior also, for either the medial or lateral meniscus. And it's very important because even in partial meniscal root tears, it has been observed that this causes extrusion of the meniscus. This is some cases, some own cases. It's a female patient, 15 years old, with a avulsion of the lateral meniscus, and here is the same patient, another patient with lateral meniscus, concomitant ACL injuries, and in the top of the screen, in the bottom of the screen, you can see the different shape of medial meniscus tear because they are particularly degenerative tears in older or middle-aged patients. Is it new? No, it's not new. The first reference was in 1991 in a 21 years old football player with a severe injury with a PCL tear and medial collateral ligament tear. And after 3 months, they scoped this patient and they found the complete avulsion, the complete root tear of the medial meniscus. And of course, we can see here in the MRI the extrusion of the meniscus. But in 1991, we didn't pay the appropriate attention in this clinical entity. First of all, we must go back to the basic science. The basic science because the meniscus is a tissue that is very crucial for the knee stability, the knee lubrication, the proprioception, and of course, what is most important is the load bearing and the shock absorption. And as concerning the root tear, this is the area that we convert these radial forces to hoop stresses. So if we have a root tear, either complete or partial, it's something like a complete meniscectomy. And this is mainly for medial root meniscus tears. In fact, we have two different clinical entities. The traumatic root tears, especially for the lateral meniscus and especially with concomitant with ACL injury, ACL tear, and we have the medial meniscal tears, that is degenerative root tears, mainly in middle-aged patients or older patients, mainly in female patients, in obese female patients, and without a trauma. We have seen from the literature review that the incidence is not so low. Up to 30% of medial meniscus tear occur in this posterior root attachment. And all the percentage of all meniscus arthrogroup is almost 10 to 20%. And what about the lateral meniscus root tears? It's mainly with the ACL tear. 80% of the lateral root tears are associated with ACL tears, and 10% of ACL tears have concomitant lateral meniscus root tears. So we must identify these tears and we must treat them, especially in the young patients, in the lateral meniscus appropriately. And a quite recent review about pediatric and adolescent patients found out that it's quite often, almost 20% of these patients had meniscal root tear, especially with an ACL tear. The natural history of these tears is very important because we have what we call it the extrusion of the meniscus. And if we don't have meniscus under the tibia and the femur, and this is catastrophic for the knee. And let's see here a patient with a ghost sign, and you can see here the ghost sign we'll talk about later. And after 6 months, it's a completely disappear of the medial meniscus, and it's a new chondral lesion for this patient. So There's also very important this study 10 years ago from Selbourne, because retrospectively they compare 33 patients with ACL reconstruction and root tears and 33 patients with ACL reconstruction without root tears. And they found a similar clinical result, but a significant, in 10 years, a significant lateral joint spatial narrowing, concerning that these patients are young patients because of the ACL tear. And for the last, in Korea, they found out in 200 patients with total knee replacement that almost 80% of these patients had a medial root tear. It was very common in female patients, and it was very common in obese patients. What about the diagnosis? The diagnosis. This is there's no signs, special signs, so there are no special complaints. There's a posterior pain. There's a tenderness in the knee. Maybe some patient complained about the popping sound, especially in squatting or descending stairs. In some patients, we can find out McMurray or Apley test positive. But there's two signs. One described from Roman Sale in 10 years before. They applied varus stress in full extension, and they had this popping of the extrusion of the meniscus. And a similar test from a Turkey, from Akmes, in figure 4, they put the knee from flexion and extension, and they found a tenderness. That means that we have a root meniscus tear. But the diagnosis is confirmed from the arthroscopy, of course, and from the MRI. Some years ago, the sensitivity and specificity of the MRI was not so clear, but if we combine the axial views, the coronal views, and the sagittal views, we will find these three signs. First, we will find the truncation sign. There's a gap between the body of the meniscus and the root tear in the axial view. Second, we have the ghost sign, almost disappear of the dark side of the medial meniscus, and then we have a transverse this fluid. That means we have a tear of the root in the meniscus. And the specificity, if we combine all these axial, sagittal, and transverse views, it's almost 100%. And here, in our case, we have this truncation side, the ghost sign, and let's see the arthroscopy view of completely tear of the medial meniscus. And there's, of course, the extrusion. If this distance is more than 3 millimeters, we're talking about extrusion of the medial meniscus. There's some classifications. It's more appropriate for the medial meniscus, the classification of Laprade, with a partial meniscus root tear completely, the most common, combination of tear with a bucket handle tear or a bony avulsion. So, well, now in 2022, we have the motto of save the meniscus, and that is why it's very crucial to diagnose the meniscus tear and to treat them appropriately. The treatment depends on the age of the patient, of the BMI, if it's trauma or not trauma, of the symptoms. Of course, for the medial meniscus, if there's osteoarthritis in X-rays, and of course, if we found chondral lesions, severe chondral lesions, grade 4 or grade 3 at arthroscopy, and of course of the experience of the surgeon and the tools that he have. There's some algorithms, but it depends on all the previous characters. The treatment options are conservative treatment, of course, for elderly patients with advanced degenerative changes, with rest, ice, non-steroid anti-inflammatory drugs or analgesics, with physiotherapy, and maybe with brace. And of course, there's partial subtotal meniscectomy. What about the conservative treatment? From this study, in 33 patients, only 33 patients with a short follow-up, only 2.5 years, 6 weeks celecoxib or ibuprofen or paracetamol with tramadol, and 12 weeks supervised physiotherapy, they have improvement in Lysol score, in Techno score, in VAS score in the first 6 months, but in only 2.5 years, they have worsening in OR as it was done from the X-rays, and 2 patients in 2 years, they came for a total knee replacement. So, is there a space for partial or subtotal meniscectomy? It's what happened in the other lesions of the meniscus. We have this meniscectomy, the partial or subtotal, only to relieve the mechanical symptoms. I repeat, only to relieve the mechanical symptoms. Some years ago, in 56 patients with a follow-up only less than 4 years, they found out that the partial meniscectomy provides symptomatic relief in most cases, but that does not arrest the progression of radiographically revealed osteoarthritis. And in these retrospective studies, with 26 patients with partial meniscectomy and 26 patients with conservative treatment and a follow-up in 5 years, they have the same clinical results, and they have worse outcomes in patients with partial meniscectomy. Almost 50% of them, they became total knee replacement patients. So there's no space for actually conservative treatment or treatment with partial meniscectomy. We must think about the repair. When? In acute traumatic cases, especially for the lateral meniscus and especially with young patients with ACL tear, and in chronic cases, in young patients or middle-aged patients without severe osteoarthritis, without malalignment, and without severe humeral lesions in the arthroscopy. Nowadays, we have some special instruments like this from the shoulder arthroscopy. This is a special knee scorpion, and of course the tunnels for the tibial tunnel, like the ACL reconstruction. In fact, we have the pull-out technique with 1 or 2 tunnels, and then we can stabilize the repair with a netto button, with a button, or with a post screw, or with a bone bridge. In this case, a female patient, 15 years old, we have the avulsion of the lateral meniscus, and then we can see the first try in the anterior horn of the lateral meniscus, and then the second try in the posterior horn of the lateral meniscus. We can see the tunnel for the ACL reconstruction, and then we pull the tape and the tape, and we can see that it's secured in the anatomical position of the lateral meniscus. It's the same for the medial meniscus, but sometimes it's too late because we have, like here, some chondral lesions, but we have the complete avulsion of the medial meniscus. We are using the same instruments like ACL reconstruction for performing the tibial tunnel, and the final view is that view from this patient. And sometimes, especially for lateral side, for lateral meniscus, we can perform a side-to-side repair, like a rotator cuff side-to-side repair. With an all-inside device, we can repair the meniscus in a case like this. It's a rather difficult situation. What about the literature review? If we see the most recent reviews and the meta-analysis, we can find out that the meniscus root repair leads to significantly less arthritis progression and subsequent knee arthroplasty compared with non-operative management and partial meniscectomy in a matched cohort based on patient characteristics. And what about the meta-analysis? The first meta-analysis with 88 studies and 235 patients find out that there's a very good result as concerning the clinical result, the scores, the progressions of arthritis and the cartilage status they did not prevent it, but completely. But of course, it's better than not doing anything. And the second meta-analysis, more recent, with 13 studies and comparison with per group, they find out the same result, that they have better clinical result, but the progression of knee arthritis was less severe after the repair than it was after partial meniscectomy. So, in conclusion, it's not so rare cases, of course, both for the lateral and the medial meniscus. It has a difficult diagnosis, but we must inspect the MRI signs very carefully, and we must remember that the appropriate treatment, especially in young patients or middle-aged patients, is the repair of meniscus. Before closing, I would like to invite you the next Congress of ESCA in April, and of course in our Congress in Greece, in Thessaloniki, in next June. Thank you very much.